Hello, everyone, and welcome to CCCF. I'm Mika Hamilton. I'm an anesthesiologist and intensivist at University Health Network. I'm an assistant professor at the University of Toronto, and I'm going to talk about early mobilisation in the ICU, the year in review. I don't have any conflicts of interest to disclose. So I'll just start by talking about what does mobilisation actually mean and look like in the ICU. Well, just going back from what I see, it can be, passive and active movements, patients doing range of movement exercises, dangling on the side of the bed, focused respiratory physiotherapy, patients sitting out in the chair at the side of their beds for a few hours a day, standing at the side of the bed, doing a few steps in their room. And my favourite is when we see patients doing laps around the ICU. And it makes me happy to be told to get out of the way when we're on our ward rounds so that our patients can complete their laps. But what considerations do we have to think about prior to moving a patient? Well, there's many. Does the patient have pain? Are they anxious? Are they agitated? Are they going to desaturate? How much oxygen are they on? How much vasopressor are they on? Are they going to drop their blood pressure? Do they have fractures? Do they have important lines and tubes that we don't want to pull out by mistake? In addition to all these considerations, we have to also think about our human resources as well. Do we have enough staff on the unit to actually move patients as much as we want them to? And sometimes that can be challenging. So why do we do it? Well, lots of physiological reasons why we do it. Mobilisation of secretions, mobilisation of edema, improving the micro and macro circulation, preventing muscle atrophy, and hopefully actually building up some muscle strength, improving patient stability and balance, hopefully, increasing oxygen saturations through increasing their pulmonary reserve. There are many physiological reasons why we want to move our critically ill patients. But why do we really do it? Well, we want our patients to get strong and we want them to get home. When they get home, we want them to be able to be strong enough to do the things they need to do to give them a good quality of life, whether that's getting back to work, going out into the garden, doing their shopping, being able to bathe and dress themselves. These are all things that are important to the patient when they leave the hospital. And we also want our patients to feel well also. And I will talk a bit more in a moment about the link between exercise, mobilisation and mental health. Because it is important to our patients. Our patients leave the ICU, their journey does not finish at that point. They may go to the ward, they may go to rehabilitation, they may go home. If they get home, they may not be at a level of function that is acceptable to them, and that they had before their admission to ICU. So it's very important to try and improve patient outcomes as much as possible, even after they leave the ICU and we may not see them anymore. Why is weakness on the ICU so important? Well, because unfortunately it increases mortality. Now, our sicker patients are the patients who are more likely to develop ICU-acquired weakness, but even independent of that, the development of weakness on the ICU is an independent risk factor for increased mortality on the ICU and increased length of stay. So we should work as hard as we can to try and prevent this from happening or treat it if it does happen. So there's been lots of thoughts about this for many, many years. Looking back, the first studies examining physiotherapy in critically ill patients seem to go back into the 1960s. The first proper focused study that I could find was this one from 1995, and this was basically a study of continuous passive motion of one leg of patients who were paralysed for 7 days on the ICU because they were being mechanically ventilated. Now, luckily, we don't need to paralyse patients for that long, usually, but this study looked at what would happen if you did continuous passive motion of one leg and not the other leg in these patients. And they did this for 7 days. They did muscle biopsies after 7 days, and what they found was that there was preservation of muscle in the moved leg, and there was atrophy in the leg that was not moved. And in some patients, there was actually a slight increase in the muscle fiber cross-sectional area. So that showed us at that point that, yes, there are things we can do to preserve the muscle in ICU. And just generally, this systematic review from 2013 shows that physical therapy in ICU patients appears to confer significant benefit in improving quality of life after ICU, improving physical function, improving peripheral and respiratory muscle strength, increasing days off the ventilator, and decreasing ICU and hospital length of stay. And I said I would talk about exercise and mental health. Well, it is well known and well documented that exercise has a positive effect on your mental health. Why? Well, luckily there's entire books written about it, and you just can see one example here. So many mechanisms are discussed. Some of the main ones that come up are that regular exercise seems to have a negative effect on the hypothalamic pituitary axis. That's a part of the brain that secretes stress hormones, namely cortisol. And regular exercise is thought to stimulate that part of the brain to the point that where then you do get a different stressful situation that occurs. The HPA does not secrete as much stress hormone as usual. Regular exercise is associated with increased growth hormone levels, and in association with that, reduced levels of inflammatory mediators, and is also associated with increased levels of brain-derived neurotrophic factor. Now, that's a hormone that is associated with increased neuroplasticity in the brain, so connection between neurons. Regular exercise is also thought to protect the areas of the brain that are most sensitive to chronic stress and aging against volume loss. And in fact, intense exercise has been shown to increase those areas of the brain. And then just generally, moving and exercising is associated with more social interaction and motivation, and these are protective against depressive and anxiety symptoms. Structured exercise programs are shown to be more effective in reducing the burden of depressive symptoms compared to no treatment, and are shown to be just as effective as medications and or psychotherapy. And how much exercise? Well, probably public health recommendations are optimal. This research article here, Exercise Treatment for Depression, showed that if you followed the public health recommendations, which in North America at that time was moderate activity for 30 minutes a day, which is about brisk walking, that significantly reduced the burden of depressive symptoms. Less exercise was also helpful, just not as much so. And we see similar effects in anxiety as well. Anyway, I'm supposed to talk about the year in review. So I'm going to start by talking about the TEAMS trial. Now, technically, this was 2022, but it was November, and this is November 2023, so I think I can talk about it, and it is a very important trial to talk about. So the TEAMS trial basically looked at early active mobilization compared to usual care, and it was a randomized controlled trial across 6 countries, where 750 intubated patients were randomized to early mobilization or usual care for 28 days. The goal in the intervention group was the highest level of activity possible for the longest time, day to day, but this was tailored day to day, and this was within 72 hours of enrollment. There was no difference between the groups in days off of the ventilator or out of the ICU, survival at 180 days, or functional outcomes. And it was shown there was a higher risk of adverse events in the early mobilization group, comprising desaturations, bradyarrhythmias, and 1 stroke. Now, that seems a little disheartening, but some things to say. So there was a higher than usual level of mobilization in the usual care group. And I think this brings up a good point that we don't really know what usual care is now. It's possible that, we've talked so much about early mobilisation over the last few years. Is usual care actually just moving more towards early mobilisation? Therefore, were we just comparing an intervention to something very similar? There was also some crossover between the treating clinicians, the physiotherapists, in some of the early mobilisation groups and the usual care groups. So suffice to say, we may have been comparing early mobilisation to something similar to it. So that's why I think it's important not to be too disheartened by the results. However, the incidence of adverse events in the early mobilisation group is definitely something that we need to focus on and discuss. This was another trial published this year. This was a stepped wedge cluster randomised study, included a couple of thousand patients, and was designed to assess patients who had been ventilated for more than 48 hours, designed to assess their mobility prior to leaving the ICU. So the intervention group basically had, within 72 hours of their admission, had daily goals with regards to their mobilisation, posted in their rooms, posted on their notes, and communicated with the team. And this was compared to usual care. What it was found was that the patients who had the intervention did not have improved mobility by the time they left the ICU, but they were more likely to be able to stand. And there was no difference in adverse events between the groups. Adverse events was falls and extubation. However, secondary outcomes mentioned that there were longer ICU and hospital length of stay, longer duration of mechanical ventilation, and reduced number of days free of coma and delirium in the intervention group. Now, we're not sure why this has happened. The authors acknowledge that there may not have been optimal separation between the groups with regards to the mobilisation goal setting. And there was a discussion around the frequency and timing of goals of care discussions between the groups, which may have accounted for a difference, but they did not have the data to fully explore that. Overall, though, the intervention patients did receive more physiotherapy than the non-intervention patients. This is a systematic review published in Nursing Critical Care in summer of this year, a systematic review of the effect of early mobilisation on the length of stay for adults. This was a systematic review looking at almost 1,300 patients. 7 out of 10 of the studies had a stepwise progression approach. Now that's an interesting point because the delivery of early mobilisation can be very different between different hospitals and different groups. What the systematic review found was that it favoured a reduced length of stay, but was not statistically significant. Apologies for my dog in the background. There was no difference in mortality between the groups. There was a diverse reporting of functional outcomes, but overall functional outcomes were improved in the early mobilisation group. They also showed that it was safe. And this is another systematic review, again, published this year in the Journal of Clinical Medicine, looked at 11 randomised controlled trials comparing mobilisation within 72 hours to usual care. There was no difference in adverse events between the groups, and that was falls, extubation, line removal, and cardiac arrest. And there was no difference in mortality. There was improved cognitive function and muscle strength, and less diagnosis of post-intensive care syndrome. However, the authors highlighted from this group, again, well, what is usual care? What are we comparing early mobilisation to? How do we follow our patients up with regards to their outcomes? When do we follow them up? What do we mean by early mobilisation? What dose do we use? They highlighted that there is a lot of heterogeneity in our patients, in the interventions, and in usual care. So, lots of different results, likely some crossover between these studies. So this is a meta-research protocol that has been proposed by these authors who stated that there is perhaps redundancy in conducting systematic reviews in this topic. There may be unclear justification to lead to new systematic reviews. And as we've just seen, there can be very discordant results, and that makes us hard to know what we should be doing. They have proposed a meta-research protocol to really dive into all of this evidence again, focusing on these factors. And this study was proposed in July, so it'll be important to keep an eye out for this one coming up. Now with a focus more on brain health and mental health aspects of early mobilisation, this was a study published in The Lancet of this year, particularly focusing on the effects of early mobilisation on cognitive impairment. The caveat is around 50% of our mechanically ventilated patients will likely have cognitive impairment at 1 year, affecting short-term memory, visual spatial skills, executive functioning, multitasking. This may mean that patients cannot go back to work. They might not be able to deal with the day-to-day stuff in their households that are necessary. It can be really debilitating for a patient. So this was a single-centre parallel randomised controlled trial where patients were randomised within the first 4 days of mechanical ventilation. There was about 100 patients in each group. The intervention group had assessment and treatment by a physiotherapist and an occupational therapist with progressive mobilisation. They would have their mobilisation occur at roughly 1 day after admission compared to 4 days in the usual care group. Cognitive function was assessed at 1 year using the Montreal Cognitive Assessment Score, and it was found that there was a significantly reduced incidence of cognitive impairment, 24% versus 43%. There was also a quicker degree of cognitive recovery, less weakness overall, and a higher physical component in the quality of life score. Again, however, they did see an increased rate of adverse events in the early mobilisation group. Looking at early mobilisation and delirium in the Journal of Intensive Critical Care Nursing in February of this year, this was a systematic review looking at 13 randomised controlled trials and over 2,000 patients. Early mobilisation was shown to reduce the risk of developing delirium and seemed to reduce the duration of delirium when it occurs by around 2 days. We know delirium is a risk factor for cognitive impairment, so this does make a lot of sense. Again, the authors acknowledged a lot of heterogeneity in the population, the interventions and the reporting of delirium. So this is a very interesting study, which now goes a little bit out of my area of expertise, thinking about artificial intelligence. The authors here acknowledged this heterogeneity of our patients and the heterogeneity of early mobilisation. Who benefits? When do they benefit? What is the optimal dosage with regard to timing, frequency, level, duration? This is not known, and maybe we need an individualised approach. So they undertook an artificial intelligence-based learning approach, and they divided a heterogeneous critical care cohort from 2 ICUs in Germany into 4 clusters. They looked at factors like age, BMI, frailty, where they came from, what was their Apache score, their mobility on admission, and their reason for admission. The patients were then clustered into the following groups: severely ill and frail, young trauma, old and non-frail, and middle-aged. Different mobilisation strategies in these groups supported the likelihood of being discharged home. So this is really enabling a move towards an individualised and resource-optimised mobilisation approach with regards to frequency, intensity, duration, and modality. This ties in nicely with my next slide, which is what next? Which patients benefit most? When? How? What type of mobilisation? What intensity should we use? Should it be progressive, stepwise? Should we be doing as much as possible, as soon as possible? When do we follow them up and how? How do we compare early mobilisation to usual care? What is usual care nowadays? Should it even be different anymore? Or should we just get everyone moving as soon as possible? These are many areas to focus on in the future. Luckily, there's lots of individuals, research groups and networks who are very interested in working on this. There's entire meetings devoted to the subjects. There's also a lot of talk now about the patient and their journey. ICU is near the beginning of that journey and it doesn't end when they leave. We really need to work on optimising patients' outcomes, getting them back to a good quality of life. It starts on the ICU, if not before. This is an example of a centre of research excellence which has been opened in Australia, led by a professor of physiotherapy with a focus on critically ill patient outcomes. And as part of that journey, I think early mobilisation is going to have a really key part. There's lots of focus and interest in rehabilitation of our patients. And again, I think early mobilisation has a really important place in this pathway. And in fact, these guidelines published in summer of this year in critical care looked at multimodal rehabilitation for patients with post-intensive care syndrome. They focus on the assessment, prevention, and the treatment of post-intensive care syndrome. And as part of a bundle of recommendation and acknowledging some uncertainties in the literature, a multidisciplinary task force for rehabilitation state, we recommend structured interprofessional implementation of early mobilisation of critically ill patients, according to defined inclusion and exclusion criteria, making sure it's safe, with the best possible dosage and frequency. So that's the piece that we need to work on. And these are really excellent guidelines to take a read of. So that is the end of my presentation. Thank you for listening. If you have any questions or you would like to be guided to any of this literature, please email me or you can contact me on social media. Thank you very much.